I'm Dr. Raajit Rampal from Memorial Sloan Kettering Cancer Center in New York. Today we'll be talking about escaping from cytoreduction, how to identify disease progression in patients with polycythemia vera. We should begin by defining what do we mean by escape from cytoreduction. We know that patients often require cytoreductive therapy, but how do we monitor for disease progression? This can take several forms. One is frank disease progression in the form of increasing spleen size, increasing blood counts or poorly controlled blood counts, or disease transformation or evolution into myelofibrosis or acute leukemia. The advent of thrombotic events while on therapy also represents an escape from cytoreduction. Progressive symptom burden, and finally, resistance or intolerance to the cytoreductive therapy itself all represent forms of escape from cytoreductive therapy. What are the indications for using cytoreductive therapy in the first place in patients with polycythemia vera? Well, there are a number of different factors to consider. One is patients who are at high risk of a thrombotic event based on risk factors, such as an age greater than 60, or a history of a thrombotic event. The requirement for phlebotomy, which is frequent or poor tolerance to phlebotomy. Symptomatic or progressive splenomegaly, severe disease-related symptoms, and platelet counts or white blood cell counts that are poorly controlled. We know from several studies that patients with polycythemia vera are at risk of having disease progression and evolution. Patients may transform from polycythemia directly to acute myeloid leukemia. As well, patients are at risk for transformation into myelofibrosis. The median time for leukemic transformation is approximately 4.6 to 19 years, whereas for myelofibrosis it ranges between 8.5 to 20 years. The percentage of patients who evolve over time does change with the duration of the disease, where 7.9 to 17% of patients may experience leukemic transformation at 20 years of disease duration, whereas the cumulative incidence of transformation to myelofibrosis is 26% at 20 years. Several risk factors have been identified relating to the odds of progression and evolution. For patients who transform to myelofibrosis, risks include the age of the patient, the presence of leukocytosis, the disease duration, the amount of reticulin fibrosis, and the presence of splenomegaly. For patients who transform to acute leukemia, risk factors include the age of the patient, leukocytosis, reticulin fibrosis, and again, splenomegaly. Genetic risk factors for evolution to myelofibrosis include the presence of the JAK2 mutation, and for evolution into leukemia, risk factors include an abnormal karyotype, the presence of a p53 mutation, and the presence of a RUNX1 mutation. As well, patients with polycythemia can have a number of different symptoms, and these include symptoms such as fatigue, abdominal pain, early satiety, night sweats, pruritus, and bone pain. Importantly, not all patients have the same symptom burden, and in fact, data from the Mayo Clinic has demonstrated that patients with polycythemia often have different symptom clusters. Patients with more mild symptoms may only experience fatigue, whereas patients with more moderate or high symptom burdens may endure symptoms such as pruritus, high levels of fatigue, insomnia, early satiety, and abdominal pain. Importantly, when we consider thrombotic risk assessments, there does not appear to be an association between a patient's risk group and their symptom cluster. However, symptoms and their symptom clusters do associate with the spleen size and the white blood cell count. Thus, the presence of worsening symptoms in conjunction with the presence of worsening white count or spleen size all collectively may indicate the presence of escape from cytoreduction. As well, individually, worsening symptoms or worsening blood counts or spleen size may also indicate escape from cytoreductive therapy. We must also consider that the cytoreductive therapy itself may produce side effects in patients. For example, in patients taking hydroxyurea, 20 to 25% of those patients may develop side effects on hydroxyurea. These include leg ulcers, myelosuppression, hyperpigmentation, fever, and alopecia. Patients may also fail to achieve their targets using hydroxyurea and may develop resistance to hydroxyurea, whereby patients have increased symptom burden, as we have discussed. This, importantly, is associated with a reduced survival. Other modalities, such as phlebotomy, can also have side effects, such as fatigue, cognitive impairment, and increased pulmonary artery pressure. Indeed, resistance and intolerance of hydroxyurea has been formalized by the European Leukemia Net into criteria which include the need for phlebotomy to keep hematocrit under 45% after 3 months of at least 2 grams per day of hydrea, or uncontrolled myeloproliferation, which includes elevated platelet count and white count after 3 months of therapy with at least 2 grams per day of hydrea, a failure to reduce massive splenomegaly by more than 50%, as measured by palpation, or failure to relieve symptoms related to splenomegaly, a reduction in the absolute neutrophil count or platelet count or hemoglobin at the lowest dose of hydrea that is required to achieve a complete or partial hematologic response, and finally, the presence of side effects from the hydroxyurea, as we have discussed. Thus, to conclude, despite therapy with cytoreductive agents, patients may experience disease progression. Patients may escape from the effects of cytoreduction in several ways, which includes disease progression or evolution, the presence of new thrombotic events, symptom progression, or intolerance to the cytoreductive agent itself. It's important for clinicians to keep each of these factors in mind when assessing a patient's response to a cytoreductive therapy. Importantly, studies have begun to address this patient population. For example, the RESPONSE trial, which has evaluated the role of ruxolitinib in patients who have had resistance or intolerance to hydroxyurea. Further efforts in this patient population are ongoing. Thank you for your attention.